which today's webinar is about issues that we face as patients and families, and what are the solutions. So Dr. Brijesh sir has kindly agreed to answer these queries which patients and their families might have. So I'll quickly go through the agenda so that we have more time to discuss about the problems. First, we'll be having a welcome note given by Sajani ma'am. Second will be Dr. Brijesh sir will be giving a little talk about CHD. Then we'll quickly move on to the question answer session, which will be facilitated by me. And next, after that, we'll have a vote of thanks given by Antalika. And finally, I'll be closing the webinar. Hopefully, we'll be done by 9:30. I think that's the time given to us. So I call upon Sajani ma'am to give the welcome note.
Thank you so much, Sujasmita. Let me just straight up get into the duty that is visited upon me of welcoming Dr. Brijesh sir, like his family member. So there is no need for me to welcome him with the additional thing like flowers and all. We are just offering our hearts to you, and we know that the hearts of our kids are safe with you, sir. A very warm welcome to you to this session, and please, the moment we got our kids, the concerns started, and you are here to address all our concerns, and that makes you almost equivalent to God. We cannot converse with God, but you are his representative here. Thank you so much for being here, sir. And welcome to all the parents. I'm sure all your concerns and all the questions that you have in your mind would be answered by Dr. Sir. So please, Dr. Sir, let's get into that meeting. Thank you so much.
Thank you. Thank you for inviting me for this session. I've been with this group, I think, for some time now, and has been hearing few concerns from parents regarding their children with heart disease. So what I'm planning today is, I thought I will give a little bit of brief introduction, and each one, whoever has doubts regarding care for congenital heart disease, their kids, what to do, maybe I can help out in a little bit on that. So last time I have given an overview regarding congenital heart surgery, how things are going around. This time probably I will give a little bit overview about taking care of child. If you look at it, there are a spectrum which there is a section of heart disease where following treatment you have a complete cure. It's simple A receptor defect, PDA. So there are these constitute close to around 20%, probably you can say 20 to 25%. So these lesions, once you do surgery or an intervention and treat them fully, then there is no need of further actual long-term follow-up. You follow up with a team probably for a couple of years, and then there is no need of any further follow-up. And second, there is no need of any medications also. Then there is a large group of lesions which constitute a tetralogy of Fallot, a certain section of tetralogy of Fallot, transposition of aorta, a complete AV canal defect. Like that, they are slightly more complex heart disease. They constitute probably another 50% of them, where they are usually corrected by a single heart, surgery or mainly a surgery, usually when the child is less than 1 year old. And then they require a constant surveillance with a pediatric cardiac team. Constant surveillance in the sense that in the first year following surgery, as you know, they may be followed probably 3 or 4 times. And then usually it's a yearly follow-up. This is they also lead a normal life. They often will not require any medication, but we advise them for a follow-up because they can have minor problems in later life. For example, if you do a complete repair of a transposition, call it as a TGA, where the correction is done early in life. Sometimes these children can have later valve problems like a aortic valve leak or a pulmonary valve leak or a pulmonary stenosis. These sort of lesions can happen later in life. So to detect them early, we advise a yearly follow-up. And these are also correctable lesions. You can treat it fully, but they have to be treated on time. And many of these children will be completely asymptomatic during the follow-up, and only the doctor by an echo can pick up that the lesions are developing quite early before they develop symptoms. So that's why they are advised yearly follow-up. They also lead a normal life and often does not require any medication. Then there is a subset of lesion. We call it as truncus arteriosus, tetralogy with pulmonary atresia. Like that, there is a set of lesions which may require multiple surgeries. Most of this reason for multiple surgeries is because these children does not have a proper connection of a heart with the lung. Normally, in normal people, blood flow from the heart to the lung via pulmonary valve through the pulmonary artery. There are a complex set of lesions, as I mentioned earlier, where these children does not have a pulmonary valve, nor they have a pulmonary artery, proximal pulmonary artery. Pulmonary blood flow into the lungs is normal. So these set of children often, when you do a primary correction early, will require a conduit. We put in a tube with a valve in it. We call it as a conduit between the heart and the lung. Now the problem here is, as the child grows, the conduit does not grow. So at a finite period of time, you need the conduit to be replaced. So initially, when the child grows, probably when the surgery is done in the initial time, the first conduit replacement might be required probably in a 3 or 4 years. And then the next conduit is usually around 10 years later, and then probably at the adult. Usually we say most probably around 3 or 4 times. And they are not all of them are open heart surgery. Initial surgeries are open heart, but later surgery can be done transvenous. So they need a finite number of surgeries in life, but again, they usually lead a near normal life. Then there is a subset of lesion which you call it as a single ventricle lesions. So they, as you know, undergo a three-stage surgery.
Yeah, breaking up, doctor. Your voice is breaking up. We're not able to hear you. Yes, the connection went from there. Right. Let's just wait.
Undergo a three-stage surgery, and the child is 6 months of age and a functional single ventricle. That's why you call it as a single ventricle lesion. So when you do correction, you give this ventricle directly to the body and connect the circulation directly to the lung. So it's a three-stage surgery, and the final surgery is called as the Fontan surgery. So these children definitely will require a regular follow-up. What we see with these children is that they also will be able to lead a near normal life. They will have often a little bit of problems which may require medications, but regular life they can often do the routine activities except for the very strenuous activities. Now, do they develop problem? Yes, they may develop problem, but usually in very later life. You see it probably in the late fourth decade of life or the fifth decade of life. Some children can develop problem early because of their lesions, heart lesions, because this single ventricle lesion is a quite a multiple level of lesions. So these children will have a definite follow-up is required. Then the last subset is those children who have a very complex heart disease. So this very complex heart disease, sometimes these children can live for a finite number of years without even surgeries also. So I have often seen this subset being discussed in this group. So these children will often require a treatment as well as information on child basis. means you have to give the information I give for one child may not be applicable for another child because they are having a complex heart lesion. So they have to have individual information depending upon this lesion. So generally what I can tell you is that except for the first subset of lesion which I have discussed like a very simple heart disease, the others will require constant, probably a yearly follow-up. It doesn't mean that they are always have to be attached to the doctors and always has to see the doctors. It just means that they have to see a very good group of hospital where they are linked with it, but they have to have a yearly follow-up. That is what it means. Now, in the other section, what is happening is that, see, the congenital heart disease has been corrected. Most of these children, as they grow, now, if you see outside country, there is a program for these children who have been treated and have attained beyond 18 years, especially the third and the fourth subset, where I told about the single ventricle lesions or the complex heart disease lesion or the lesions require multiple surgeries. So when they cross the 18 years of age, there is often a confusion whether they should go to the pediatric heart program or they should go to the adult heart program. So as you know, as I've seen you discuss, there is a GUCH which is known as the congenital heart disease in adults. So if you see outside India, there are definite GUCH clinics which is especially seen in the developed countries like Europe or in US. But when you come to India, here the GUCH clinics are not really developed. This is because, see, the congenital heart surgeries at the highest level, treating all forms of lesions has probably been in India only for a couple of decades. Prior to that, corrections have been there, but it's not has been the focus where you have a focus correction for all lesion. So this focus care for congenital heart disease has much developed in India for the last couple of decades only. So if you look in that sense, when you look in that sense, the children with advanced heart disease probably growing beyond the 20 years the India is now facing only. So if you look at major centers, if you look at the major centers in the country, they have often developed a GUCH clinic. Like in AMritha, we have now presently a GUCH clinic for adult congenital heart disease. So the set of problems, as you know, the set of problems faced by these children are
I think we lost his
entirely
connection.
different. This there is a general discussion I told regarding what you need to know. Now probably I can take your questions and move into the individual people having their problem.
Okay, thank you, Dr. Brijesh sir. This was very informative. So we'll move on to the question and answer round.
Okay.
The first question will be asked by Rizma. Rizma, you can ask your question.
Sir, my question is, I have some few questions. So first one, I would like to ask you that Fontan, it should be done at some early age or as late as possible. And if suppose we wait, then does the pulmonary artery size decrease or the pulmonary artery pressure increase or some scar tissues are formed? Does it happen if we wait for Fontan?
See, general dictum which I can give for Fontan is ideal age of doing Fontan is usually early when the child is around 5 to 6 years of age. So beyond 4 years of age is the usual age what we follow here. We don't do Fontan less than 4 years because for the Fontan to be effective, the child should be walking. So the early Fontan where the child has not started walking, that may affect the Fontan circulation. Second thing is that in Fontan, unlike the first stage, you need a tube to be connected. So basically, you need a tube to be connected from the IVC directly to the heart. So it means that you need to put in a tube which should be okay for as the child grows. When they become adult also, that tube should be sufficient. So to put in the tube, at least you need the child to be older by around 4 to 5 years of age. So that is the ideal age. Now, can we wait to do it Fontan? Then the answer for that is, suppose due to certain reasons, the Fontan surgery is not done and the child has grown to 10 years or 11 years or 15 years, still Fontan surgery can be done in this subset of patients. It can be done later also. There is no problem that it cannot be done. But beyond, when the Fontan surgery is done, when you become an adult, then it definitely has its problem, because the risk as well as the complication that may arise when you do a late Fontan is often higher than what you do when the child is around 5 years of age. Now, the other question which was asked was that, is there a problem if you waited that the pulmonary pressure may rise? See, this can be answered only on selective cases, because there are certain factors which comes in if you do Fontan later. Depends upon whether you have an additional blood flow to the lung, whether one of your blood arteries are not grown. Those factors depends upon individual people. So unless we see the whole data of yours, as well as whether because you need to know a lot of factors in deciding whether the Fontan would be ideal or not. So doing Fontan later is okay, but the main thing is whether there are certain criteria to be filled for the Fontan to be successful. Now, Fontan to be successful be done. Second, reasonable amount of arteries. If the pulmonary arteries are not grown, third, your AV valves, tricuspid valve, they have to be functioning normally. So the more than the factor that you do later Fontan, the trouble is whether any of these factors are there when the even after you do the Fontan, you have the persistent factors, then Fontan will give you trouble. So doing Fontan late is okay. Ideal would be at 5 years, and the long-term effect of Fontan depends upon these factors what I've told you.
Okay, thank you, Rizma. The next question is coming from Antalika. Antalika, you can go ahead.
Yeah, good evening, sir. I'm Antalika. So my son he's diagnosed with subpulmonic ventricular septal defect. Initially, when the initial diagnosis came, he also had he had multiple atrial septal, it was diagnosed as a fenestrated atrial septum with a subpulmonic ventricular septal defect. But right now, he's 7 years old, and all these other holes have closed, and the concerning one is the remaining subpulmonic defect. So he has not been there has been no intervention till now for him, because the size is quite small now. It started as a moderate, it was classified as moderate, but now it is classified as a tiny subpulmonic VSD. So, sir, my question is I have not been able to find any literature or any kind of this thing specifically with subpulmonic VSDs. Can you shed some light on the normal path of these, like how these lesions normally progress? Is surgery always required, and will it always be an open heart surgery only if this defect has to be repaired? Because what the doctors initially told me, that there was a chance of aortic regurgitation and aortic valve prolapse with these lesions. It is highly likely. And they actually kind of informed us that these lesions will never close on their own. They are not like muscular VSDs, which have a tendency to close. So, but for my son specifically, the size of the lesion has reduced over the last 7 years, and now it is classified as a tiny VSD. and he is under a yearly follow-up. Currently with no aortic regurgitation or aortic valve prolapse. So I just want to, can you shed some light on the, like normally the pathophysiology of this kind of a lesion, like how it normally progresses?
Yeah, so I got it. So see, subpulmonic VSD, your child is 7-year-old. The child ASDs have closed, and now the child has a very tiny subpulmonic VSD.
Correct.
So
Yes.
the treatment for this child is, if the subpulmonic VSD is tiny, it is not causing any other lesion, you don't need to treat it. Okay. The child can live a normal life even if the child has a very small VSD. You don't need to close all the VSDs. Only thing is, second question is whether it will close by its own. Subpulmonic VSD is less likely to close by its own. Even if the size comes down, it is less likely to close by its own. Okay. Child will not have any trouble. Only thing is, if you take the child to any pediatrician, if they put in a stent over the chest, they will hear a very loud murmur. That is only problem. Okay. And those pediatricians who don't know about the heart disease may get panicked, and they may advise you that there is a major lesion, you need to consult the doctor. Okay.
Yes.
There is no problem. Now, there is only one problem with subpulmonic VSD is that, as the doctor who has informed you earlier, the aortic valve is lying very close to the VSD. Okay. This aortic valve can prolapse through this VSD, and the child can develop an aortic regurgitation. Okay, that is a serious problem. Okay, this is the serious problem is because, one, even if the aortic valve prolapse and the child develops aortic regurgitation, child will be absolutely asymptomatic. Okay, child would be absolutely asymptomatic until your aortic valve completely gets destroyed. Okay, then you end up with replacing the valve. Okay, so what happens is, many of the parents get panicked because this is a thing which is hanging around. Okay, and they always feel, no, we have to do something for this child. So what you need to know is, see, there are different things in your body which can happen, and because of those things, complications can happen. Okay, just because the complication happens, you don't need to treat it. What you need to know is, subpulmonic VSD cannot be closed by a device. Okay, unlike other VSD, if you put in a device, what happens is it can cause definitely aortic valve damage. There will be certain pediatric cardiologists who are really enthusiastic and may put in a device, but it is not recommended. Okay. And second thing is, there will be certain people who really wants to close all VSDs. Still, we don't recommend closing all VSDs. If you go by any criteria worldwide, internationally, they don't recommend. What you need to do is, you have to every year do one echo for this child. Okay, and see whether the valve have started prolapse or not. There would not be any aortic regurgitation. The usual pathway for this child will be, if at all the valve starts leaking, it would be like, first echo will show aortic valve prolapse. Okay, and after probably a finite number of, it may be 1 year, some children it will be 6 months, you see a mild AR. Okay, and then it becomes a moderate AR, and finally it becomes a severe AR. Okay, so this cannot happen overnight. It happens only over many months or over years. Okay, so you need to do every year one echo for this child. It's not just physical examination, you need to do an echo. And the first evidence when it shows the aortic valve prolapse, close the VSD. Okay, so this can happen only in probably 30 to 40%, 60 to 70%, nothing will happen. Okay, the ideal age when it happens is usually up to around 15 to 20 years. If it has not prolapsed by 20 years, it is very unlikely to prolapse after that. Okay, so just follow it up with yearly echo. And if the first sign you see the aortic valve prolapse, don't think about any intervention, just go and get the surgery. Surgery is absolutely safe in this. There is no problem, 100% safe. And child, even now or even after surgery, will never require any medication. Okay, but just because we can treat it, we don't advise to do surgery. Okay, he has to show some indication to decide whether he needs surgery or not. Okay.
Right. Thank you so much, sir. Thank you.
Thank you, Antalika. So the next person who has a question is Durga. Durga, you can go ahead.
Hello, sir. I am Durga. My daughter has heterotaxy right atrial isomerism. She has AVSD, LTGA, obstructed TAPVC. Currently, Glenn has been performed with TAPVC repair. My questions are, will there be any option available if Fontaine is not feasible? Can a CHD kid live a normal life with only Glenn? Will breathing issue may arise due to LTGA? And my last question is, she has some amount of pulmonary stenosis. Will it help to keep her saturation in a normal level?
Okay, so what you need to know here is this is a complex heart disease. Okay, so I would require a lot more information before I give you your answer. So I will ask those questions. So how old is the child exactly now?
Durga, can you hear, sir?
I think muted, I think.
Durga, you need to unmute yourself and answer the question.
Hello?
Yes,
Yeah.
go ahead.
Yes, sir. What do you ask?
How old is the child now?
She is 2 years old.
2 years old. So the child has undergone only TAPVC, total anomalous pulmonary venous correction.
And Glenn surgery.
Pardon? And Glenn surgery. Okay, okay, got it. So what is the saturation of the child now?
Now 84, 82.
Okay. So see, in a corrected TGA, now the child has TAPVC correction with the Glenn surgery. The saturation is 84 and the child is 2-year-old. Okay. And the child lesions currently are corrected TGA with VST with pulmonary stenosis. Correct, no?
Huh.
Yeah. So see, since the child is 84% saturation, with this lesion, as the child grows, the saturation is going to come down only. Okay. So the child will require definitely one surgery. So what you need to know is this surgery is one of the most complicated surgery. So the surgery, what we call it is, child will require Sennings plus Rastelli operation. Okay. Now, this surgery, when it should be done, and now the child is 2 years old, you can plan this surgery anytime from 2 years to probably around 5 years. That would be there is no rush to do surgery since the saturation is around 85%. But if you delay the surgery too long, the problem is surgery becomes more complicated. So I would advise to do surgery when the child probably in the next couple of years. That is the ideal time. And second thing what you need to know is this surgery, the second stage surgery is a very complicated surgery. So you have to plan this surgery in centers which are capable of doing this complex heart surgeries. Double switch, we call it as Sennings plus Rastelli, is probably done only in a very few centers. The first stage surgery, which TAPVC with Glenn, probably is a much more easy surgery. The second surgery, as you say, is a total correction surgery, Sennings plus Rastelli. So what I would advise is you can plan your surgery probably in a 2 to 3 years time. It requires adequate planning. It not only requires an echo, you need an cath to be done prior to surgery and then plan the surgery. A CT also might be required because it's going to be a redo surgery. So a cath plus CT might be required and then you have to proceed with surgery. So you can plan in a 2 years time. And third thing is you should undergo surgery in a center which is capable of doing this surgery. And the last question is, after you do this corrective surgery, the child's saturation will usually come back to normal, but the child will require every year a strict follow-up because there can be problems. One problem is in future whether the child require any more surgeries. Yes, the child may require further surgeries because, as I told you, this surgery which the child is going to undergo will require a tube to be put or a conduit we call. and this conduit needs to be changed in future, probably 3 more time. But with all these factors, I will still advise you to go ahead with surgery, because if you don't do surgery over a period of time, the cell saturation will come down and the child will have problem. So plan surgery in the next couple of years in a center which is able to do this surgery. Okay.
Okay. Thank you, sir.
Okay.
Okay, thank you, Durga. The next person is Bhargavi. Bhargavi, go ahead with your question.
Yeah, sure. Thank you. Hi, sir. This is Bhargavi from Hyderabad. I have a daughter who has a congenital heart disease called HLHS, a single ventricle, and heterotaxy syndrome. So until now, she never asked me regarding the scar that she has, but I'm thinking that she might ask. I want to know how and when to tell the child that they are different from the other kids, and how will they take it, and what will how will it impact their health. This is one question. I also want to tell you that my child is having high LVEDP pressures, and hospitals in Hyderabad have denied doing the fontaine. So I would like to know if Amrita had handled that cases, and how was the recovery? How are the patients doing right now?
Okay. Regarding the scar, what I would advise the parents is, you have to tell this. There is no point in hiding the scar from the child, because as the child grows, the scar will always creep in, and as the child understands more and more, they will definitely ask this question. So it is always better, even if the child is fully corrected, always to tell them that they have undergone a surgery, and the surgery, as a surgery, that scar will be there, and as the child grows, the scar will come down. Okay. If you see the way the children are treated outside our country, they always take it, these children take it, the scar as a pride. Our problem is the parents here, as well as all of us, are always much worried about the scar anywhere in the body. So always we speak to these children like, you have a scar. It is put forward as a negative thing, and this comes always in their mind. What you need to know is, scar, as the child grows, scar will be there, but there are now lot of options available with the plastic surgery, with the recent advances, where if you have an hypertrophic scar or a keloid, you can treat it. So scar is not at all a problem. Now, regarding the second question, see, HLHS is a single ventricle lesion. Okay, so the child has undergone two operations, what we call it as the Norwood operation, as well as the Glenn. Now the child requires a fontan, but the hospitals are denying operation because the child's LVEDP is high. So what you need to know is, it's actually not that the hospitals are unable to do it. Here the problem is, if the LVEDP is high, then fontan surgery actually should not be tried, because if the LVDP is high, if you do fontan, later the fontan will fail and the child will have more problems. Okay, so LVDP high is definitely a problem in this child. So how you need to treat this children is, you have to give certain medication. I don't know what all medications they have given. You need to know further details regarding the cath, whether it's only an LVDP high, or is there any other factors which is in preventing doing a fontan, and you have to medically treat these children now. And you will have to later follow up this child, again do a cath after giving medication, probably 6 months or 1 year later, and see whether the LVDP has come down or not. Usually what we see is that there is a section of children whom the LVDP is high initially, but usually it comes down. And once it comes down, we can proceed with fontan. Okay, so basically we need to follow up these children and see all these reports, the cath report, and then medically treat these children, and later do a cath after probably 6 months or 1 year from now. And if the LVDP has come down, proceed with fondant. So that is what I would recommend for this child.
Okay, sir. Sure. Thank you.
Okay, thank you, Bhargavi. So next question is from Tarun. Tarun, go ahead.
Hello, sir. So actually, like my son has diagnosed with the CTGA when he was 1 year old, and now he's 5.5 year old. Everything is fine. So, but I'm a bit worried about like what could be the problem that we can face in future, and what is the way to correct it, and what could be the possible things that that I need to be taken care as he's growing.
Okay, so I would require again a few more details. Now the child is 5 year old. You said that the child has corrected TGA, CTGA. Does the child have associated VST or pulmonary stenosis?
No, he's
No.
absolutely fine. There is no problem so far.
No problem. So basically, it's a corrected TGA alone.
Okay.
Okay. So corrected TGA alone, the treatment is slightly controversial. Okay. Why? Because see, there are two things. One, what happens if these children are not offered surgery? Okay. If surgery is not offered, then usually they live towards 5th decade of life. That is the natural history. Okay, that means the child will live probably, I'm saying the average. There are people who have lived with the corrected TGA to 70, 75 I've seen, but there are people who have got problems in the 4th decade. Okay, but generally corrected TGA alone for the first 35 to 40 years, usually there is no problem. Okay. That is generally okay. And what problems can they arise? This cause is, see, corrected TGA. The problem here is your main ventricle, which is supplying the body, is the right ventricle in this child. Unlike normal people, where it is left ventricle. Okay, so right ventricle is actually not naturally formed to support your whole body circulation. So they usually fail after around 40 years of life. That is the natural history. Okay. Now, there is also one more problem these children can have, which is rare. That is around 10% of these children can develop spontaneous heart block. That means that their heart rate can come down. Okay. So there is a subset of people who believe that these children, if it is a corrected TGA alone, okay, with having no other lesion, just leave them alone. Okay. Because they have a natural life to around 50 years. Now, what is the alternative option? Alternative option is a double switch operation in these children. Now, what is the problem of this double switch is that, one, it is a very complex operation. Okay, it has got a mortality risk of around close to around, I would say, 5 to 10%. Okay, and if you do the surgery, is the problem over? No. Even after surgery also, these children can develop problem, because sometimes what we see is that after double switch, a 5% of children suddenly can develop heart failure in the next 5 years of life. Okay. Again, another 10% can develop rhythm problems. Okay. So if you see in certain Western countries, they are very aggressive. They go ahead with double switch. Okay. There are certain Western countries, they just follow these children without any surgery, because these children really lead a normal life for around 40 to 50 years. So what we follow in AMritha is that if the corrected TGA is alone, child is completely okay, then we usually don't go ahead with a double switch operation. Okay. We offer a double switch operation if there are associated lesions the children are having, or associated problems with corrected TGA. Okay. So if your child is 5 years old and having absolutely no problem, our approach is to follow these children yearly, and if accordingly give treatment for the child. Currently, the child will not require any medication. You just need yearly follow-up. Okay. But if you want to pursue this surgical option, this is also the correct age to do the double switch operation. Okay.
No, definitely I will not go with that. So first, I would like to share my screen to see the report because I'm very new with all these things. So can you check and tell me like if you are okay? Can I share
Yeah,
my screen? Okay.
no problem.
Can somebody give me the host access?
Arun, you screen share. You share.
Okay. Okay. So this is the report that I got after the echo when he was 1 year old.
Congenital heart disease transfer. So this is basically this echo report suggests a corrected transposition without any lesion. Okay.
Okay.
So from our clinic, what we would advise is just follow up.
Okay. And sir, like what are the precaution I should have with my child? Like,
see, you can just leave the child like a normal children. Okay, you
okay.
need not control them in any way, except for very competitive sports, very high competitive sports. You can just avoid, even though the child will be capable to do it. Okay, this is
Okay.
just because to prevent a further load onto the ventricle, but otherwise, just tell the child you have a lesion, but no problem. You live as you want. There is no problem. Okay. Only thing is you just need to yearly follow up, and always at that follow up you may have to do an ECG also. Okay.
Okay. Sure. I will do. Thank you.
Okay.
Okay, thank you, Tarun. So next we have Rizma again. So Rizma, go ahead. Rizma, you can go ahead with your question.
Hello, sir. So in our last cat, it was written that the pulmonary artery size is smaller uniformly. So that means in the future, which one is more likely? Say, it will be a requirement, heart transplant or heart lung transplant. It was written as smaller uniformly. And then second one is the pulmonary artery pressure is higher for Fontan. So does it mean that it will lead to pulmonary hypertension?
So I need a little more information. How old is your child now?
11 years. 11 years.
10 years. Okay. So the
11.
child has undergone Glenn procedure, but what I got the information is child has undergone Glenn procedure. Fontan procedure has not been done because pulmonary artery growth is less, as well as pulmonary pressures are high. Correct?
Yes. Yes. Yes,
Rizma,
sir.
we can't hear you. Yeah, go ahead.
Correct.
Yeah. So the problem here is, see, again, as I've told you earlier, Fontan surgery, it's not that the center is not doing Fontan surgery. Fontan surgeries can only be done if your pulmonary artery size are good enough or your pulmonary pressures are low. Both has to be okay. Now, this is not a case where the child develop pulmonary hypertension and all. These children never develop pulmonary hypertension. What the problem here is, if you want to do a Fontan procedures, your pulmonary pressures have to be reasonable. It has to be below 15. Okay. If your pressures are above 15, the Fontan procedure cannot be done, because in Fontan procedure what you are doing is you are connecting the veins directly to a pulmonary artery, and there is no pump to contract. Basically there is no ventricle to push it in. So if the pulmonary pressure is high, if you do Fontan surgery, the blood will not reach the lung, it will just flow back, and the child will be much sicker than before. Okay, so the surgery can only, so at 10 years of age, if your pulmonary artery sizes are less and the pulmonary pressures are high, then the chance for surgical correction is much less. So the child will require medical management. So you need to have a close follow-up with a pediatric cardiologist, continue the medication, and the surgical option Fontan, I think, will be very difficult. Okay. And whether transplant and all, transplant, what you need to know is transplant is the last step. Just because surgery is not possible, nobody should go for. There is a tendency now to go for a heart transplant or a heart lung transplant just because Fontan is not possible. No, that is not the way. Heart lung transplant or the heart transplant is advised in congenital heart surgery only at the last step where the child is extremely sick and is unable to move forward with medical management. Okay. So what I would advise here is to continue the medical management, consult your pediatric cardiologist and follow them. And the transplant option is the last option, which you can just keep aside now. Okay.
Sir, I have a question. Is there any yoga or something like that to make that our pulmonary artery to make that changes?
No, see, currently the yoga therapy is advised for Fontan in those people who have undergone Fontan to make their life better. Because see, what happens in a natural history of Fontan is, as I told you, around 40 years or 50 years. Okay. Usually, generally, after your third decade, late third decade, their pulmonary, they develop symptoms because your pulmonary bed is unable to cope up with that circulation. So, if those children who have undergone Fontan follows a regular lifestyle, like they avoid very strenuous exercise. Second, they avoid smoking or any of those habits. And third, they do regular yoga, not the extreme yoga or the pranayama, regular yoga, so that your pulmonary bed improves and is able to get the blood flow. Then what we see in this subset is that their Fontan, they are able to lead a near normal life for a prolonged period of time. Okay. But if your blood vessels have not grown or the pressures are high, then we won't recommend yoga because these children will not be able to do those sort of exercise.
Okay, thank you, Rizma. Next, we move on to Shondipan. Shondipan, you can go ahead with your question.
Yeah, thank you. Actually, my nephew has CHD. He is born with CCTGA, VSD, and pulmonary atresia. So he had undergone a Glenn operation at 9 months of age. So now what happens that when he plays or when he runs around, he gets tired. Too often he gets tired. So now the doctors are planning for the Fontaine operation. He's 6 years of age, 6.5. So just can you tell me that why he gets tired? So sometimes he vomits also because he gets tired. He vomits after bathing. He vomits often because sometimes he also gets tired after bathing because while bathing he plays. So that's why he gets tired. So can you tell me, doctor, about this?
So the child has a 6-year-old now with a corrected TGA, CCTGA, VST, pulmonary atresia, and a Glenn surgery.
Yes.
Okay. So
Glenn
what
surgery.
you need to know is, see, Glenn operation, the child will have a good saturation probably by around up to 3 or 4 years of age. Okay. After that, as the child grows, his saturation comes down because only around 50% of the blood is going into the lungs.
Okay.
So you need to do surgery for these children. Okay. Now, what is the ideal surgery? If corrected TGA, VST, pulmonary atresia, post Glenn, the ideal surgery is again a double switch operation. Double switch in the sense that a Sennings plus Rastelli. Okay. The easier option is a Fontan operation. Okay. Now, whether the child is suitable for a corrected double switch operation, we need to know further information regarding you need to do a cath, CT, and those evaluation. Now, whether the doctor has advised you Fontan, there are two reasons for it. Because one is after evaluation, they have decided that you are not a double switch candidate. Second is that center is not doing it. Okay. What you need to know is as I told you before, double switch operation, mainly the sending rastral is done only in very few selected centers. Okay. So what I would advise is you need to take the child to a higher center, have a detailed evaluation with the doctor there. Certain centers in North India as well as in South India are doing double switch operation. So you need to go to a center which is doing this operation and see whether double switch is feasible or not. Double switch, what I mean is sendings plus rasterly. Okay.
Okay.
If sendings plus rasterly is possible, I would advise to do that rather than a Fontan. Okay. But if sendings and rasterly is going to be high risk, okay, then go ahead with Fontan. Okay. Whatever be the case, you need to undergo the second stage. There is no doubt. He's 6-year-old. You need to undergo the second stage. Otherwise, the child will become more and more sick as he grows. Okay.
Okay, sir. Okay.
So take the child to a higher center. Have a detailed evaluation. If they say that the child can undergo a double switch with less complication, go for it. If they say that the child's double switch is too high risk and they recommend Fontan, and they do a cath and say the child Fontan can be done, go for it. Okay.
Okay, in that case, which one is more beneficial, a Fontan or a double switch?
If double switch is possible, that is the primary option. Okay. But sometimes because of its anatomy, double switch becomes a very high risk operation. Okay. Very, very high risk. If that is the case, I would tell the second option, Fontan.
Okay, sir.
Okay, thank you, Shandipan.
Okay, one more question. Okay, sorry to interrupt.
Go ahead.
Question.
No, go ahead.
Yes. My nephew has a mild AVVR. So is it problematic?
Mild AVVR is okay. So with mild AVVR, still I would suggest double switch is a better option always. Okay.
Okay.
So take him to a center which is doing reasonably double switch. And if they have that experience, if that team has this experience and evaluate and then tell you that they can do it, go for it. But if they evaluate and say that it's not possible, it is too high risk, then go for a fund.
Okay. Thank you.
Okay. Thank you, Shandipan. So the next person is Priyanka. Priyanka, go ahead with your question, please.
Good evening, sir. Myself, Priyanka.
Okay.
Sir, my question related to Fontaine procedure. Like hello.
Yeah.
Like my son is a 7.5-year-old and had Fontaine when he was 5-year-old. So my question is, how is the prognosis of Fontaine? Sir, what are the outcomes of Fontaine procedures? Long-term side effects on the others organs like liver, kidney, and lungs. What we can do to minimize the side effects of the anticoagulant medicines and एनवास लाइक एनवास सर मतलब हम लोग क्या कर सकते हैं कि कम से कम साइड इफेक्ट्स हों मेडिसिन के और अदर ऑर्गन्स पे कम से कम इफेक्ट पड़े फॉन्टेन्स प्रोसीजर का.
Okay, so what are the medicines the child is taking now?
Sir, he has had acetrom 1 mg and 1.25 mg alternate day and Anvas 2.5 mg once a day.
Okay. See, the child is now 2 years after Fontaine.
Yes, sir.
See, I need to see the detailed report. See, there are different ways Fontaine children are followed in different centers. Okay. So, in AMritha, what we follow is we give acetrom only for the first year after Fontaine.
Okay, sir.
And if your Fontaine anatomy is good, then we stop acetrom and convert it into aspirin. Okay. This is basically because, see, managing acetrom in a children is very difficult. You need to do a monthly blood test, and then sometimes you need to give injection, and then again heparin, and again add acetrom. And if the child requires a tooth extraction, you have to stop altogether, start injection. All these problems are there. Okay. So what we generally do in AMritha is we give acetrom for first year, and then we change over to aspirin. Aspirin is fine because it doesn't require any injections, and then major procedure if you have to undergo, you just need to stop for a couple of days. You don't need to give any injections. Okay. So that is the first thing. Second thing is regarding NVAS. Generally we give for the first year, and then we stop NVAS also. Okay.
Okay.
So the way these children are followed is slightly different from center to center. Okay.
Yes, sir.
So that is what first thing I will tell you. Second thing what I would tell you is how to take care of these children, allow this child again to lead a normal life. Okay.
Yes,
Except for very strenuous activities like going for a swimming. Okay.
yes, sir.
Those sort of high intensity activities, just stop it. Otherwise, the child plays in a ground. Don't tell them don't play. Don't make them sit at home and all. Allow
Yes.
the child to do a reasonable amount of activities. Again, I need to look at your report before finally telling, because I've not seen your recent ECHO report.
Okay.
Okay.
Okay, sir. Okay. I will send it. Yes.
But this is the general thing what we advise for a fontaine. And if you ask me what is the normal life expectancy, everything, this is what I told you. Fontaine again is not a no. You are not corrected the heart fully. You are given a correction by which the child can live a reasonably normal life. Okay.
Yes.
So these
Yes.
children generally, if things are all right, we usually till 40 years of age, they don't have much of a problem. They can
Yes,
have
sir.
minor problem, which is always treatable. But
Yes.
beyond 40 years of life, they generally will have ventricular failure, which requires intense medication and
Yes.
further treatment. Okay.
Yes.
So
Yes.
currently what I would advise is, again, it depends upon your center. If your center is choosing to give both medication, follow that.
Yes,
Okay.
sir.
Or get an advice from another center.
Yes.
Second thing is yearly follow-up is a must. And
Yes.
currently allow the child to do the routine activities.
Okay. Okay, sir. Thank you, sir.
Okay. Thank you, Priyanka. We move on to the next person. Mahesh, you can go ahead with your question, please. Mahesh, are you there?
Mahesh, can you?
Can you mute Mahavir M11? I guess it's not muted. So can you mute with mic? Mahavir M11. I don't know who is joined in that. Yeah.
Isn't Mahesh here?
Mr. Mahesh,
महावीर तुम बोल सकते हैं ना?
is it Mahesh Appu? Is Mahavir Mr. Mahesh?
I don't know. I think so. That's right.
अच्छा. हेलो महेश सर, आप वहां पे हो? आप सुन सकते हो? Hello. Let's move on to the next person then.
Okay, so we come back to Risma. She has a few more questions.
Okay, no
And
problem.
then we can go ahead and ask anybody else if they have any questions. Go ahead, Risma.
My next question is, will my child suffer too much physical pain inside her chest in the future? And another question.
Sorry, madam. I just want your child has undergone fontan surgery, no?
No, sir.
No, sir. She had gone through
Only Glenn.
Pardon?
Glenn.
Glenn. Okay, this is the child with the corrected TGA.
No, tricuspid atresia, pulmonary atresia. Just now I asked you that about
Okay,
this.
I got it. So the pulmonary pressure is slightly higher side.
17 and 18, yes.
Yeah, the pulmonary arteries are small and pulmonary pressure is high, so you have not undergone a fontan. Okay, so your question is whether a child can have problem, how in future, that is your question?
Will she have some pain in her chest?
Okay, see, what you need to know is this children with congenital heart disease, the pain in the chest is a very non-specific and it is usually not related to the heart disease. Okay, unlike adults where they can have chest pain, children will not have chest pain because of the heart disease. They generally will have blue discoloration, or when they play they may have a breathing difficulty, but pain is not related to the heart disease. Okay, so if your child is complaining of about chest pain, it is usually a bone pain or a muscular pain. Okay, so you need not worry about that.
Okay, sir. Actually, she has not complained about it. I was just thinking that in future, like I have seen some older people having some chest pain due to heart problem. That's what.
He is
No, no.
considering me and her daughter. That's why.
Okay,
I had
okay.
a chest problem. You know why? Because it is.
Yeah. This is very unrelated. Don't worry. So generally, children with heart disease, they don't have chest pain or a heart attack as you see in adult. Okay. So what you need to watch for your child is the child can have more of bluish discoloration. Okay, so since the child cannot undergo a Fontan correction, the child will require constant medical supplementation. And if the child develops more of breathing difficulty or the child develops more of bluish discoloration, you need to consult the doctor and adjust the medicines accordingly.
Another question that is about the cause of CHD. So I'm not a person of I'm not related anyhow to biology, but still in some articles I have seen that as a cause of CHD, I have found mother's age, mother's obesity, something like mother's mental health, all these things during pregnancy. So nothing is there about father. So is it completely or responsibility is completely on the mother's side, sir?
See, this very often I get this question. See, I will answer it in two phases. First question they ask is, see, parents usually come to us whether it's a mistake on their part because they have taken some medicine or they have a fall or there is a family history that they develop heart disease. What I need to tell you is heart disease, the child developing is completely unrelated to any of the problem the mother is having. Okay, heart disease happens 0.8 percentage in 100 birth. Okay, so if 100 children are born, one child is born with heart disease. This is a constant factor whether you are in India, you are in abroad, wherever you are. So it's not related to obesity, it's not related to mother having diabetes during pregnancy, or it is not related to any trauma, or not related to any medicine the mother is having, nor to any infection the mother gets during pregnancy. Even I am hearing about COVID nowadays. No, it's not related to anything. It's that just that it happens by chance. Okay, so 1 in 100 will have heart disease. Now the second question is, if I have a child with heart disease, whether if I am having a second child, is there a higher chance for developing heart disease? Yes, it's a higher chance, but the chance is only 2%. So if you are having a pregnancy, what is the chance for heart disease? It's 1%. If you are having one child with heart disease, if I am becoming pregnant again, is there a chance? It's 2%. So what it means is that even if you have a child with heart disease, your next pregnancy, 98% it's going to be normal pregnancy, and it's completely unrelated to any of these factors. And third thing, final, what I need to tell you is, currently there is a technology by which to know whether during pregnancy whether you have heart disease or not. It is known as fetal echo. It is not the routine ultrasound. I've again seen many parents come to me and say that we have done ultrasound during every month of our pregnancy. Till pregnancy, none of the doctors told us that the child has heart disease, and as soon as the delivery happened, we are having a child with heart disease. What do you know? What you need to know is, none of this ultrasound can pick heart disease. You need to do a typical specific type of ultrasound known as fetal ultrasound. This is generally done by a pediatric cardiologist and generally available only in very few centers. But now almost all the state, at least few people are there who does it in all the states. If you see in Kerala, there are around 8 to 10 people who are doing. In Tamil Nadu, it's available. In North India also it's available. So if routinely, if you need to do it, no. But if you have a child with heart disease, you want to undergo one more pregnancy, then get that it needs to be done only once, and it needs to be done in the 4th month of pregnancy. Once you have completed 3 months, just undergo a fetal ultrasound, which will say whether your fetus is having heart disease or not. Okay.
Thank you, sir. Thank you so much. Thank you. Thank you, sir.
Yeah, sorry. Sorry. Thank you, Rizma. Sakshi has just joined and she has a question. So Sakshi, you can go ahead and ask your question, please. Sakshi?
Sakshi ma'am, you are muted.
Muted. Yeah, you're muted. Please unmute.
Yeah, sorry. Actually, I have a question, ma'am. I have a baby boy and the age is 5 months, right? And when he was born, we do not know about his heart defect. He has AVSD, and the LVO2 size is 3.9 when he was born, and now he's 5 months. Yes, 5 months running, and it's on growing stage, and the LVO2 is 3.9 and now it's 4.9. So what are the chances कि वो कितना कब तक वो grow हो जाएगा और कैसे मतलब सही रहेगा, and मतलब these are the question that is running in my mind about LVO2 specifically.
See, the child is now how many months old?
5 months.
5 months old. So the child has an ABSD only. There is no other lesion.
No. Sorry.
Yeah.
Sakshi, can you repeat your answer? We didn't hear you.
See, are you listening?
Yeah, go ahead. Can you repeat yourself once more? We didn't hear you.
See, I have a baby boy and the age is 5 months, right? He has a problem of AVSD, large VSD and 5 some ASD, right? And the second question, and basically the second problem is of LVOT that I was asking with you, if you remember.
Yeah. So my question is, have you shown to any pediatric cardiologist?
Yeah, we
What
yes.
have they advised? I think you are muted. Yeah. What have they advised, pediatric cardiology?
उन्होंने मैम सर यही एडवाइस किया, एज द एज इज यू नो व्हाट, जैसे जैसे एज बढ़ेगा वैसे वैसे इसका साइज भी पॉसिबिलिटी है बढ़ेगा. दे कॉल इट एज वॉल्व ऑब्स्ट्रक्शन.
It's usually at this time you need to treat these children. Okay. So you need to usually we don't wait it. Okay. So have they told it's a pulmonary obstruction or an aortic obstruction?
Sir, that I do not know, because they said कि valve obstruction है और उसका closed heart surgery हम करा चुके हैं.
No. I think if you can send me that echo report, let me go through it, because if you have an AVSD, generally surgery is done in the time of 3 to 5 months. We don't do
AVSD plus narrow valve size, narrow valve.
Yeah.
It is,
so I need to know whether it's a narrow valve is pulmonary valve or aortic valve.
That I have to ask whether.
Yeah. So if you can send me the report, I can go through it and then advise. Because if it's a pulmonary valve, we tend to wait.
Yeah, they said कि हमें wait करना चाहिए. It will be grow naturally. वो naturally grow होने का wait कर रहे हैं. That is why we are waiting. अभी तो at the time of birth it was 3.9, right? अभी my baby is 5 months running and it's 4.9. So it is on growing stage.
Okay, so you can send me the echo report. I need to look in that report, because the advice given is not what we routinely follow. Okay, so if you can send me a detailed echo report, I will look into it and then advise. You can share it with Apu. Apu knows my number and other details. Okay, so let me look into that echo report. Okay, then I will be able to tell you.
Okay. Okay, because ना, you know what, sir, doctor, जो doctor हमें consult कर रहे हैं जिस doctor से, his name is Ashutosh Marwa, and he's in Apollo Sarita Vihar, Delhi.
Okay. I know.
So he's the treating doctor. तो उन्होंने ही हमें बोला कि आप wait करिए और it will be grow as he grows. Baby जैसे जैसे बढ़ेगा.
I think the child might be having pulmonary stenosis. Okay, if the child is having AVSD with pulmonary stenosis, generally, if the child is 5 months, we wait and then we do surgery when the child is around 1 year of age. Okay, but if you can share
Right,
the echo
yes.
report, I will be able to tell you, because it depends how severe the obstruction is. If the obstruction is not severe, you need to proceed with surgery now. If the obstruction is severe, then we tend to wait. What is the oxygen level of this child?
Normal, it's last we checked it जब हम गए थे, it was 95 के approx.
Okay, then if you can send me the echo report, I will have a look at it.
The doctor said everything is okay and baby is gaining weight and everything is going good, and the LVO2, LVOT is also growing. AVST के लिए then when, because they are waiting to grow it, मतलब 1 year के approx they are waiting, कि बोल रहे हैं कि हमें wait करने को, जैसे ही वो बच्चा grow करता है और LVO2 अपना LVOT जो है अपना size ले लेगा which is 8, जो 8 होना चाहिए, उसके according वो हम open heart surgery के लिए हमें suggest कर रहे हैं फिर.
Okay, I need to look at the report because there is a little bit contradictory findings are there. Let me have a look at the report and then I will be able to tell you.
Okay, we'll send it to you, sir. Sorry.
Okay, no problem.
Okay, thank you, Sakshi. So Priyanka has another question. We'll just take 2 or 3 more questions and then wrap it up. Otherwise, we won't be able to finish it in time. So Priyanka, go ahead.
Okay. Sir, my other question is, Fontaine kids में सर हार्ट फेलियर के क्या चांसेस होते हैं और हम मतलब इसको कैसे टैकल कर सकते हैं, क्या इससे कैसे डील कर सकते हैं, अगर कुछ होता है तो कैसे हमें पता चलेगा सर हार्ट
Fontaine
फेलियर?
करने के बाद.
Yes sir, after Fontaine.
So after Fontaine, what you need to know is this heart failure is not uncommon. It doesn't happen immediately. Only in a very, very few subset of patients it develops. Okay.
Yes,
so if the heart failure develops, it's usually very, very late. As I told, it's only when you reach around 40 to 50 years. Okay.
Yes.
So then how you can detect the heart failure is as they develop heart failure, you see them, their legs become swollen. Okay.
Yes.
When they walk, they will develop breathing difficulty and
Yes,
the abdomen becomes tense with fluid.
Yes,
These
sir.
features their saturation usually slowly comes down. It doesn't come down very fastly, dramatically, but these are the signs which shows that the child is developing heart failure.
Yes sir. Okay sir, thank you so much.
Okay. Thank you, Priyanka. Appu, are you going to ask the question?
Yeah, sir, there is a question that as the technology is growing, if there can be a possibility to get alternate option for the double switch?
For the double switch?
Double switch.
Difficult. See, the problem here is it's an anatomical problem. Okay. If you have an anatomical problem, the anatomy has to be corrected. Okay. If you have a simple problem like a hole, I think a technology over a period of time will develop where you will be able to close the hole without surgery. Okay. But if a corrected TGA is a lesion where it is abnormally connected, okay, in that sense, the surgical, what we are doing is we are dismantling it and connecting. Okay, so wherever you need to cut it and suture separately, then it is very unlikely that technology will develop to that level so that surgery can be avoided. Okay, but what you need to know is corrected TGA is a very varied spectrum. Okay, corrected TGA alone is there. We've seen today corrected TGA with VST can develop, corrected TGA VST pulmonary atresia can develop, corrected TGA with the valve lesion can develop. So it's an enormous spectrum, and the treatment for each is different. Just because you have corrected TGA doesn't mean that it is the same treatment for another child. Okay. So as we have seen, a corrected TGA alone, no other problem, we tend to leave them alone. Okay. Corrected TGA, VST, pulmonary stenosis with balanced circulation, we leave them alone. Corrected TGA with pulmonary atresia, then you need to do surgery. You invariably will need to do a double switch. Okay. So it is individually depending upon the lesion and depending upon the child's status, we decide. But those lesions which need to undergo double switch will have to undergo double switch, even though it's a higher risk operation. It needs to be done, because if it's not done, as we have seen, one child where we advised double switch, the child will have to undergo double switch, because as the child grows older, the child's saturation comes down rapidly. Okay.
Okay, thank you, Apu. And this will be the last question, and I'm going to ask that. So, my son was diagnosed with pulmonary atresia after he was born. His case was very complex because he didn't have any pulmonary artery. I mean, there wasn't the natural branching or anything. So, and his circulation is basically dependent on 4 MAPCAs. And he has a VSD. So doctors, like we consulted 4 or 5 doctors in Kolkata, as well as we had gone to Narayana, Bangalore, and we consulted Dr. Kona Samba Murthy from Hyderabad. So all of them basically told us that his condition is so complex that they do not advise surgery or unifocalization surgery for such patients. Dr. Kona Samba did actually give us an option, but he wasn't very encouraging as far as the surgery went. He said that he'll basically unifocalize the MAPCAs and then connect it with the subclavian artery, I think. So the point is, we were told that my son is going to be under medical management. Now everybody tells us we'll be under medical management, but right now the symptoms which we see is his hemoglobin is very high. It's in the range of 22.5. And his iota, last when we did an echo, his iota was moving to the middle of the heart. So how do we, address these issues? And his oxygen saturation is more or less in the range of 60 to 70%, and it has been like this for over a year now. It doesn't change. So that way our pediatric cardiology is like his oxygen saturation is at least stable, so we can wait a bit.
How old is he now?
2 years 10 months.
And no surgery has been done?
No, nothing.
Okay. It's a difficult situation. See, what you need to know is tetralogy, pulmonary atresia, MAPCA, where the native pulmonary arteries are not there. Okay. In that situation, surgery is extremely complex and extremely multi-stage. You have to do multiple stage surgery. Okay. Very multiple stage surgery and interventions, multiple surgeries, multiple intervention, and the results are not exactly great. Okay. So generally what we tell these children is, if you don't have native pulmonary arteries, if you have MAPCA, then go for medical management. Okay. Now, here, if you move forward, what happens is whether your MAPCA is able to supply enough blood to the lung. That is the question. Okay. So here the problem I see is 2.5-year-old, you have multiple MAPCA, saturation is really low. Okay. Yes. So 60% means saturation is low. Your hemoglobin of 23 means the saturation is really low. So if we continue medical management, the saturation is going to come further down only. Okay. Now, what else we can offer is a unifocalization surgery, but unifocalization surgery is possible or not can only be assessed if we do a cath procedure. And if you go ahead with unifocalization, it is going to be you have to do unifocalization. It's a very, very high risk procedure.
Mm-hmm.
Okay. Now, if you see here, who is the person who is doing this lesion in India, this sort of extreme complex is Rajesh Sharma. Have you met him?
No, I haven't spoken to him yet.
Okay, so that I would advise you just show all these reports to Dr. Rajesh Sharma. If unifocalization decision has to be taken after examining, looking at all the factors only. Okay, generally, as I told you, we tell them medical management, but since your child is 60%, I don't think medical management is going to improve his situation.
Okay.
Okay, his saturation will come down only. So there are two options now available. Okay, the first is whether unifocalization is possible or not. If unifocalization is not possible, what else can be offered is temporary solution. Okay, temporary solution, what we do is we stent the MAPCA. Okay, and make the MAPCA bigger. Again, whether it's possible or not, we need to see the angio, we need to see the MAPCA sizes where they are supplying and all. Okay, but the problem with stenting is it is again a temporary solution. If you do the stenting, the saturation improves from 60 to 80, but after few years, maybe after 6 years or 10 years, again the saturation can come down. Okay. So moving forward, unifocalization is the only option, but whether it can be done at this age, you need to have a comprehensive evaluation. I would say you can contact Dr. Rajesh Sharma. He's probably the only person. You've shown the second best person, who is Sambamurthy. You've already shown him. Okay.
Yes.
If he says it's difficult, that means it's going to be a very difficult surgery. Okay.
So there's another complication. So my son actually has a rare genetic disorder called Alagille syndrome. So and this because of this syndrome, he has the congenital heart disorder, as well as liver is equally affected. I mean, not equally, but affected. His bilirubin is always high. There's a congestion in the liver. So that was another reason why the decision was taken that not to go for a very aggressive approach in his case.
I understand. So if that is the case, I think the surgery will be very difficult, because this surgery, unifocalization, is one of the longest time consuming surgery. Takes around 14-16 hours to do it. Okay, so if that requires to be put on pump, so if you have an Alagille syndrome, then it really becomes a extremely high risk. Okay, so what we can do is continue the medical management. Now, whether how we can improve his situation now is whether we can improve his saturation by doing a temporary stenting of the MAPCA. Okay, for that you need to show to a pediatric cardiologist, who again, not the regular pediatric cardiologist. You are basically from which area? From
Kolkata.
Hyderabad?
Kolkata. So we are right now consulting Dr. Amitabh Chattopadhyay from Narayana in Kolkata.
Okay. No, I don't think you need to show to certain people who are doing this. Okay, regularly. Okay, so let me check. Okay, I will check. And I will inform Appu also regarding. There will be a couple of people whom you can consult, who will be able to do it. Okay, and then accordingly, that is probably the option I would tell. Okay. To improve his condition. Okay. But otherwise, if you see, if you continue with medical management, it is only going to, the saturation is only going to come down. No medical management medicines can increase his saturation. Okay, so to improve his condition, it's the only thing which can be offered is more of stenting.
Okay. Thank you, sir. We see.
One second.
Yes.
Yeah. So just I just had a question to ask. Yes. Yeah. Hi, Dr. Brijesh, sir. I have heard that you're also involved in funding, and also I was wondering, like, if anybody really doesn't have that kind of a money to go for a surgery, and they come to AMritha, what is the option they have? How can they apply for it? Because one or two queries came saying that they do not have the kind of a money that is required for the surgery. In such a case, if any parent actually contacts us, how do we go about it? How can we help them out about this regarding the funding part?
Yeah, see, for what we have been doing is, I work in AMritha Hospital, which is a charity hospital. Okay, so we have been helping people with congenital heart disease. Presently, if you see, in Kerala has a program, a government-driven program. But if you see any other state, that program is not there. Okay, so currently we have a system where we have children coming from all over the country, especially because we have been doing camps in selected areas, especially in areas where children are really in need. Okay, before the last couple of years, we were not able to do the targeted camp because of the corona pandemic. Prior to that, we did a big camp in actually Patna for the whole of Bihar. Then we had a camp for the Jharkhand. So we have been looking at certain states or areas where they have not been congenital heart surgery at all, not at all is available. Okay, so we currently get queries from all over the country for need of financial support. Okay, so we have actually a financial support here. Our financial model is we get support by three mechanisms. Okay, one is our own hospital funds a finite number of surgeries per year. Okay, so that is one way of funding we have. Then we have our own foundation where people can donate, and with that money we fund. Okay, and third one is we also, because of being a charity hospital doing congenital heart surgery for long, we have certain foundations within the country who as well as abroad, which helps us. Okay, so through these three routes we try and help. Currently our policy is whoever is first part we will look at when we get an application is regarding their socioeconomic status. Okay, so what we follow is generally if there is an application, we know that 99% they are unable to fund the surgery. That's why they are approaching us. Okay, so we have our own social workers who directly contact them by phone and just take their opinion, and then we ask for a few documents. Okay, generally what we ask is very simple ones. One is an echo report of these children. Second, we ask for an Aadhaar card copy, usually of their parents, just to see that the information is correct. And in only in those people whom we feel there is a need, we may ask for a income certificate. Okay, but generally we don't ask for it. So with this, depending upon this patient's capability, we fund them. Okay, there are people who we don't usually go by them. We say to us, see our if you see our rates are usually like Kerala government rates, probably 10% higher. That's our rate, and we usually look at them and ask them how much they can fund. Okay, this is because what we initially, when we started the program, we were funding fully. Okay, then we understood that many of these parents doesn't know the value about what is being offered to them unless they contribute. Okay, so we usually ask them how much they can contribute. If the parents say 1,000 rupees, that's it. We don't ask them to contribute a specific amount. There are parents who tell us that they can contribute 10,000. There are because even the foundation wants this. Okay, there are parents who say that they cannot contribute at all. We have especially those children who are coming from northeast of our country or from interior of Jharkhand, Bihar. We actually had to fund their travel to come over here. Okay, so it's that situation. So depending upon their situation, if they say they cannot fund, they ask even for help to come over here, we are able to provide financial help for their train fare, but not for flight as such. Okay, but for train fare, sometimes in selected people we have funded, and there are people who pay a little bit like 10,000, 20,000. Some people say they can fund even 50,000. Whatever they say they fund, rest we support. We have not publicized it because the problem is, as you know, once you publicize, then we will be overwhelmed with patients whom we cannot. But if you see in the last year, we were able to, our general surgery cost is something like 1.5 to 2.5, depending upon the complicated lesion. And currently last year, we were able to fund close to 25 children. Okay, so if there is a person in need who needs heart surgery, always they can approach us. I will send with Apu our foundation number and a foundation web details. So through that they can apply. Okay, There is an email through which they can apply. They just need, and there are certain people who are even unable to, they don't have the ability to send via mail. They don't have that access, especially in remote. They just need to contact us. That's enough. They just need to contact us. And we have a person called Revati with us, who is a full-time into this. And those people who cannot send by mail, they can always send by WhatsApp. We generally seen that even in remote areas now, WhatsApp is available. So they are able to send by WhatsApp, and then they can come over here. Generally, what we have seen is that simple heart lesions, we are usually able to fund. But if they have an extremely complex heart disease, okay, then we are a little bit reluctant in funding, because what we have seen is that, see, if your child, sorry, even if we fund one surgery, it is very unlikely they come for the next day surgery. Okay, so we give preference for those children who can be corrected with a single heart operation. It need not be a simple heart, it can even be a complex heart disease. But if it is correctable by a single heart surgery, we give more weightage for them. But we also correct complex heart disease, even multiple stage. But what we do is, we try to make sure that they come for the second stage. Okay, there is no point in spending money for a family who is motivated only for first stage and doesn't come for the second stage, because then we feel that we are not doing the correct. So we, for complex multiple stage surgery, we provide financial help only if we are convinced that the parents will go ahead with all the stages of surgery. Okay. So currently, from anywhere in the country, we are getting, even from Jammu and Kashmir also. So anywhere from the country, we are able to provide financial support for a finite number of children.
Sir, that Sakshi's report is with me. I can share you. Okay.
Okay, no problem.
Okay, thank you so much, Doctor. Regarding funding, I mean, we'll be able to like help so many people. Whoever comes and asks for, I'll just get them in contact with Appu, so it'll be easy for them to like stick for the funding and all. Thank you so much.
Okay. So this child, I just got this information. It's a non-restricted elevated diameter minus. How old is this child? Okay.
2 years.
So, 2 years. Okay.
Sir, any other details?
Okay, this is that previous child report with Ashutosh doctor.
Yeah.
Yes, I think so. Yes.
Yeah. So it is not an AVSD. Okay. It's a VSD, posterior deviation of the outlet system, LVOT, no coarctation, PH. Okay, so that's why it is not an AV canal defect. AVSD means an AV canal defect. It's basically a VSD with a smallest LVOTO. And
now 2.9 centimeter.
Have the child undergone a PA band gradient is 45. So I think, as the Dr. Ashutosh has said, you can wait in this situation. Okay, you can wait for some more time. Probably another, you need to undergo probably every monthly checkup and see how it is progressing, and then make a decision. Okay, definitely the child will require surgery. It's a slightly complex surgery. But you can wait for a couple of months. Waiting, there is no problem. Every monthly, probably every monthly you have to undergo follow up, and then probably undergo surgery at the end of 1 year. Whatever they have advised is true. There is no problem. Only thing here is, it's not an AVSD, it's a VSD with a LVOTO. Okay.
Okay, thank you. And Antalika, do you want to ask your question? This will be the last one.
Okay.
All right. So I had a very small question. I mean, if you allow me to ask you. So my question is very simply like we discussed about the subpulmonic VSD, which my son has. So I just want to know, since it is currently classified as a tiny VSD, and in fact, in the echo report, it said that the shunt could not be traced, like they could not trace the shunt. So is there a lesser chance of developing the AVP and AR later on? Like, is it really what I'm trying to ask is that the valve changes, is it related to the size of the defect?
It is not related to the size of the defect, but if your echo report has shown that there is no shunt at all, okay?
The shunt cannot be traced. That's
yeah, if that is the case, your chance for developing AR is very less.
Okay. That's all. Thank you.
Okay, thank you, Antalika. And I think we are done with the question answer round. So now I'm going to call Antalika to give the vote of thanks.
Okay. Thank you so much. It was really good, and I'm so happy that you were able to give us your really valuable time. I know it's the end of the day, and you must have had so many important decisions to take, surgeries to do. So I'm glad that you were able to give us this time. And I also thank all the parents and the adult CHDers who are here. And I hope for continue fruitful interaction between us. Thank you all from the bottom of my.
Okay, thank you, Antalika. I'll wrap it up now. So thank you, sir, once again.
Yeah, it's a great pleasure. I just need to tell that it's a great pleasure. I enjoy helping it out like this, and because I've been in this field and this is my profession. So anytime you call me, I will be able to spend time like this and take your queries, no problem. And in between, if you have any you want to reach me through Appu, you can send the details and I will help out. Okay.
It really means a lot to all of us, sir. Thank you so much.
Really.
Thank you so much, doctor. Really, it really feels so relieved. Initially, it was like we have to wait for a doctor. Now you're one of us. So that really makes a huge difference. We really feel blessed that you are with us, and sincerely so. Thank you so much, doctor. Really.
Thank you. Okay. Thank you.
Okay.
Thank you, sir, so much. And thank you to the people who've organized this. This was really helpful and we should do it more often. And I think everybody should take a time, go back home. We've got a lot of information regarding all the issues, even if they are not favorable for everyone. And we hope and pray that medical science also advances to a level so that everybody has an answer in the future.
Yeah.
Thank you, everybody.
Absolutely.
Thank you so much.